Immunization Technical Advisory Group, and that has been established in 134 countries. The Global NITAG network is currently available to increase this international collaboration. And NACI has been Canada's NITAG for over 50 years, one of the oldest in the world. We review guidance from other NITAGs before framing our issues, and you have a list of the other NITAG listed there. Also in Canada, most jurisdictions will also have a formal provincial or territorial immunization technical advisory group, or PITAG, such as the Comité sur l'immunisation du Québec or the Alberta Advisory Committee on Immunization, knowing that health is a provincial jurisdiction and therefore provinces and territories will adapt NACI's recommendation to their local context. Next slide, please. Alors, peut-être juste une précision pour faire la différence entre ce que Santé Canada fait et le Comité consultatif national de l'immunisation, en sachant que le CCNI est à la fois une ressource technique et un organisme délibérant qui permet aux autorités nationales et aux responsables des politiques de prendre des décisions fondées sur les données probantes. Une telle ressource est particulièrement importante compte tenu de la complexité et de l'ampleur des données probantes, ainsi que de l'interdépendance et de l'intégration mondiale des systèmes de santé. Donc, Santé Canada a pour objectif d'autoriser les indications d'utilisation particulière d'un produit qui doit être sûr, immunogène, efficace et de qualité appropriée, va se concentrer sur l'utilisation individuelle d'un produit et étudiera les données des essais cliniques soumises par les fabricants ainsi que toute surveillance post-commercialisation également soumise par le manufacturier. Au niveau du CCNI, nous recommandons des stratégies de vaccination pour promouvoir la santé, prévenir et contrôler les maladies infectieuses et nous préparer aux urgences de santé publique et y intervenir le cas échéant. Nous nous concentrons sur l'utilisation d'un produit pour des programmes publics et en termes de santé de la population et nous faisons souvent une hiérarchisation d'un produit par rapport à un autre, ce que Santé Canada ne fait pas. Nous révisons toutes les données probantes, pertinentes et accessibles sur les vaccins particuliers des préparations vaccinales similaires dans le contexte de considérations de santé publique, y compris les programmes et les calendriers de vaccination existants, le fardeau et la répartition de la maladie, ainsi que la gestion des éclosions. Et bien que tous deux, c'est-à-dire Santé Canada et le CCNI, sont sous l'autorité de la ministre de la Santé au niveau du gouvernement fédéral, il n'y a aucune hiérarchie entre Santé Canada et le CCNI. Le CCNI peut également formuler des recommandations sur les vaccins de façon non autorisée, c'est-à-dire off-label, lorsqu'il existe un besoin manifeste étayé par une analyse éthique en santé publique. Prochaine diapo. So just what we're discussing today is the release of the AstraZeneca update. So NACI has expanded its recommendation for the use of the AstraZeneca vaccine to people over the age of 18, now including those 65 years of age and over. You have to realize that when we issued a recommendation on March 1st, there was only one real-world effectiveness study that had been issued, and that study that we will discuss a bit further later on was not deemed of sufficient quality to modify policy. We have since considered two other real-world effectiveness studies that have informed this change in recommendation. While all available vaccines in Canada are safe and effective, NACI still recommends that in the context of limited vaccine supply, initial doses of mRNA vaccines should be prioritized for those at highest risk of severe illness and death and highest risk of exposure, because we have a differential efficacy estimate between the mRNA vaccines and the AstraZeneca vaccine from the clinical trials. And however, the real world effectiveness show that both mRNA and AstraZeneca have similar effectiveness, mainly after a first dose. We are also monitoring what's happening with the adverse events following immunization in Europe. And we will then let Health Canada discuss that, if ever, but that, of course, is part of the risk-benefit analysis that NACI is doing. And depending on what happens in Europe, we will revise the recommendation as needed. Next slide, please. Alors, le 26 février 2021, Santé Canada avait autorisé l'utilisation du vaccin contre la COVID-19 d'AstraZeneca chez les adultes âgés de 18 ans ou plus. Comme je vous l'ai dit, le 1er mars, le CCNI, basé sur les recommandations, sur les données des études randomisées de phase 3, avait limité l'utilisation du vaccin d'AstraZeneca aux personnes âgées de 18 à 64 ans, puisque l'estimé d'efficacité vaccinale chez les 65 ans et plus était très imprécis et incluait 0 dans l'intervalle de confiance. Par ailleurs, à cette époque-là, seule une étude d'efficacité de terrain était disponible et cette étude-là avait été jugée de qualité modeste et n'avait donc pas été utilisée pour changer la politique. Le nombre de participants âgés de plus de 65 ans ayant contracté la COVID-19 étant très petit dans les essais cliniques de phase 3 du vaccin d'AstraZeneca, il était difficile de déterminer l'efficacité du vaccin dans ce groupe d'âge. Prochaine diapo. So there's now real-world evidence from the UK who has administered the AstraZeneca vaccine to people 65 years and over. This evidence demonstrates that the vaccine is safe in those studies and effective in older adults, particularly against severe COVID-19 disease and hospitalization. In light of the new evidence that emerged in those 2 real-world effectiveness data, NACI met to review these data from the studies, 2 of which are large population-level studies of good quality, demonstrating that AstraZeneca vaccine is safe and effective in older adults, in particular against severe disease such as hospitalization, including in adults over the age of 80 with significant medical comorbidities. Next slide, please. Alors, la première étude que nous avons étudiée est celle de Hyams, dont le titre est Assessing the Effectiveness of VNT162b2 and ChAdOx1 and COVID-19 vaccination in prevention of hospitalization in elderly and frail adults, a single-center test negative case control study. Alors, il s'agit d'une étude cas témoin à test négatif de personnes hospitalisées de 80 ans et plus. Beaucoup dans ce groupe-là étaient fragiles avec des comorbidités, hospitalisés dans 2 hôpitaux de Bristol au Royaume-Uni. La vaccination a été déterminée par couplage d'enregistrement et un ajustement a été effectué pour un certain nombre de facteurs. L'efficacité du vaccin contre l'hospitalisation a été évaluée chez ceux qui avaient été vaccinés au moins 14 jours avant l'apparition des symptômes. En termes de résultats, cette étude démontrait l'efficacité de terrain d'une dose de vaccin à 80,4% contre l'hospitalisation survenue dans les 14 à 53 jours après une dose de vaccin contre la COVID-19 chez les patients de 80 ans et plus. Quand nous avons évalué cette étude, nous l'avons considérée de bonne qualité avec un faible risque de biais. La vaccination a été déterminée par couplage de dossiers et les informations cliniques ont été obtenues à partir des dossiers par des personnes qui étaient aveugles aux résultats du PCR COVID chez les participants. Cette étude présente des points forts sur le plan méthodologique et l'analyse complète se trouve dans la déclaration. Prochaine diapo, s'il vous plaît. The second study that we looked at was the one from Lopez Bernal, early effectiveness of COVID-19 vaccination with the Pfizer mRNA vaccine and the AstraZeneca adenovirus vector vaccine on symptomatic disease, hospitalizations, and mortality in older adults in England. This one is also preprint. So this again is a test negative case control study design using linked surveillance data in the UK among patients 70 years of age and older. For those who were vaccinated, cases and controls were assessed by time since vaccination to onset of symptoms, controlling for a number of factors. The impact of vaccination and hospitalization in those individuals was in age 80 years and older was also assessed in those who tested positive. The results of this study showed that one-dose vaccine effectiveness against symptomatic PCR-confirmed COVID infection in the adjusted analysis was 22% from day 14 to 20 after vaccination, which gradually rose up to 73%, 35 to 48 days after vaccination. On top of that, the effect against symptomatic disease in individuals who were 80 and over was an additional 37% protection against hospitalization within 14 days of a positive test in those 14 or more days after their vaccine dose, compared to those who were unvaccinated. We deemed this study of good quality with low risk of bias. And again, the record linkage was done using large data sets, which is a strength of this study. And again, the full analysis can be found in the statement. Next slide, please. La dernière étude qui avait été évaluée, en fait, avant le 1er mars, était celle de Vassiliou, Effectiveness of First Dose COVID-19 Vaccine against Hospitalizations and Hospital Admissions in Scotland, Effectiveness Findings from Scotland National Prospective Cohort Study of 5.4 million, which is a preprint again on the Lancet website. Juste pour vous dire qu'en raison de préoccupations liées aux faiblesses méthodologiques de cette étude, le CCNI n'avait pas utilisé ces résultats pour étayer ses recommandations. En fait, nous avions évalué que cette étude était à haut risque de biais et que par ailleurs, l'étude avait démontré une efficacité très élevée de la vaccination à prévenir les hospitalisations dans les 2 premières semaines suivant la vaccination, ce qui est biologiquement peu plausible. Encore, l'analyse complète se retrouve dans la déclaration et dans ce contexte, comme je l'ai dit précédemment, nous n'avions pas utilisé cette étude pour modifier notre recommandation. Next slide, please. So following this careful review, NACI decided to expand the recommendations for the use of the AstraZeneca vaccine to include those 65 years of age and over. NACI will continue to closely monitor data from ongoing clinical trials and evidence from real-world use of the AstraZeneca vaccine, and that includes safety, and will revise their recommendation as needed. Next slide, please. Donc, pour le futur, donc le CCNI publiera une déclaration complète référencée sur l'utilisation d'un intervalle prolongé entre les doses. Nous sommes en train de réviser les données pour le vaccin Janssen de Johnson & Johnson. Prévoyons une recommandation dans quelques semaines. L'examen du vaccin Novavax est prévu dans quelques semaines, donc nous n'avons pas encore vu les données de Novavax. Et l'examen du nombre optimal de doses de vaccin pour les personnes précédemment infectées par le SRAS-CoV-2 sera étudié dans la semaine du 22 mars avec, nous espérons, une recommandation dans les jours qui suivront. Next slide, please. You can see the full update using that link. Next slide, please. And you have NACI membership here. So as I said, this type of technical briefing will be done moving forward with every NACI release. It's not that we had anything particular to say at this point in time more than what was in the statement. And just so people know, in addition, in the interval recommendation, we are also going to be studying immunocompromised people because a few papers have been released recently. So we are keeping on top of the literature and are modifying as need be, but we know that the evidence move quickly, and so it sometimes is difficult to understand exactly what has been reviewed for which statement release. Thank you.
Thank you. Merci, Dr. Quach. We'll now move to the question and answer period. I remind you to just simply use the raise your hand feature on Zoom if you want to ask a question. Les journalistes qui veulent poser des questions peuvent le faire en utilisant la fonction lever la main dans Zoom. Alors, on va commencer cette période avec Raymond Filion. Raymond Filion, première question donc.
Oui, merci beaucoup, Martin. Bonjour. Une question peut-être pour Dr. Berthiaume qui représente Santé Canada, parce qu'on ne vous a pas encore entendu publiquement là-dessus, Santé Canada, l'histoire des caillots sanguins du vaccin AstraZeneca. Ma question, compte tenu des inquiétudes, pourquoi Santé Canada ne suspend pas le vaccin AstraZeneca comme l'ont fait une vingtaine d'autres pays, ne serait-ce que par mesure de précaution?
Merci pour votre question. Alors, Santé Canada est au courant que certains pays européens ont mis sur pause la vaccination avec le vaccin AstraZeneca. Il y a eu des cas qui ont été rapportés d'effets secondaires thromboemboliques dans certains pays européens. Cependant, je dois vous dire qu'il y a une analyse qui est en cours au niveau de l'Agence européenne du médicament avec des discussions aujourd'hui puis une réunion prévue jeudi. À ce moment-ci, sur la base des données que l'on a au Canada, le nombre d'effets indésirables thromboemboliques rapportés est très en deçà de ce qui pourrait être attendu dans une population juste par la survenue normale de ces effets indésirables-là. Donc, les effets indésirables peuvent survenir dans la population et donc aussi chez des gens qui ont été vaccinés. Ça n'établit pas nécessairement un lien de causalité entre l'événement thromboembolique et le fait que la personne a pris un vaccin. Donc, il doit y avoir une investigation poussée. Chacun des cas en Europe va être investigué par l'Agence européenne du médicament. On est en consultation, en communication constante avec eux. Actuellement, je dois dire aussi qu'au Canada, les lots qui ont été distribués ne sont pas les mêmes lots qui ont été distribués en Europe. Les lots du vaccin d'AstraZeneca qui sont distribués au Canada sont des lots qui sont développés sous licence par une compagnie qui s'appelle le Serum Institute of India. Puis éventuellement, s'il y a des lots d'AstraZeneca qui viennent au Canada, ils seraient possiblement de source d'une production qui serait autre que celle des lots là, qui ont été utilisés en Europe. Donc, à ce moment-ci, Santé Canada suit les événements, mais considère que compte tenu des risques associés à la COVID-19 et au bénéfice de la vaccination, il est préférable de continuer à être vacciné avec les vaccins disponibles au Canada, y compris le vaccin d'AstraZeneca, qui est considéré à l'heure actuelle sur la base des données disponibles sûr, efficace et de qualité.
Merci. Question de suivi?
Oui, question suivie. Donc, il n'y a aucune preuve qui démontre un lien, surtout avec les lots qu'on a au Canada, si je vous comprends bien, mais vous n'avez pas l'assurance qu'il n'y a pas de lien. Est-ce exact?
C'est-à-dire que, comme j'expliquais, ce qu'on doit garder en tête, c'est que des événements indésirables peuvent survenir suite à l'inoculation d'un vaccin. Ensuite, on doit déterminer est-ce qu'il y a un lien entre ces effets indésirables-là et le vaccin. Sur la base, par exemple, des données que l'on a pour le vaccin AstraZeneca, où presque 24 000 personnes ont été inoculées avec le vaccin dans les essais cliniques, le taux de survenue des effets secondaires thromboemboliques était plus bas dans le groupe vacciné que dans les groupes contrôle. Ce qui veut dire que quand on contrôle de façon aléatoire puis on répartit les sujets dans les études, il n'y a aucune évidence que le vaccin d'AstraZeneca à l'intérieur des essais cliniques cause des effets secondaires thromboemboliques. Je dois aussi rajouter que jusqu'à maintenant, les effets secondaires thromboemboliques ne sont pas des effets secondaires qui ont été associés de façon typique avec les vaccinations en général. Mais ceci dit, Santé Canada continue d'investiguer la chose. Au Canada, on n'a pas eu de rapport d'effets indésirables avec le vaccin d'AstraZeneca de nature thromboembolique. Il y a eu 2 cas de nature thromboembolique qui ont été rapportés avec le vaccin de Pfizer. Puis je dois dire aussi que l'information quand même que l'on a actuellement, c'est qu'il y a eu 17 millions de doses qui ont été distribuées en Europe du vaccin d'AstraZeneca et inoculées. Puis les cas rapportés sont dans quelques dizaines de cas, alors que les cas attendus seraient probablement plus dans quelques centaines de cas. Donc, il faut garder ça en tête. Il faut éviter de prendre là, des décisions hâtives sur la base des informations que l'on a actuellement. Tout semble indiquer que le vaccin est sûr à l'heure actuelle. Mais comme je vous dis, on continue de suivre la chose d'heure en heure, de jour en jour. Puis s'il y a des changements à la position de Santé Canada, ça va être communiqué immédiatement là, aux différentes instances et au public en général.
Merci beaucoup. We'll now move to Mackenzie Gray.
Hi there. My first question is for Dr. Berthiaume. I know you just answered this in French, but if you just go over to English as well, too. I mean, what's Health Canada doing to track the safety of the AstraZeneca vaccine, considering many European allies have stopped using it right now?
Yes, thank you for your question. So Health Canada is actively monitoring the ongoing situation in Europe. As you are aware, many European countries have paused their vaccination and because they're currently investigating a number of cases that has been reported in different countries that are thromboembolic adverse event. Based on the information that Health Canada has reviewed, the number of cases of thromboembolic adverse event at this point in time are lower than the rates that would be expected in the population that has been vaccinated with the AstraZeneca vaccine. So we are aware of those cases. We are in direct communication with the European Medicines Agency and with the sponsor. We are looking to get additional information about the case. The pharmacovigilance regulatory committee in Europe will discuss the issue today and will convene a meeting on Thursday where more information will be provided. At this point in time, based on the information that has been distributed by and reviewed by Health Canada, there is no safety concern with the thromboembolic adverse event because the number of events are lower than expected, but we're actively looking into the issue. So overall, Health Canada considers that the benefits of the vaccines, considering the risk of contracting COVID infection and its associated complication, outweigh any risk that potentially be associated with the vaccine.
Thank you. Follow up?
Yeah, my follow-up questions for Dr. Quach. I think it was on March 1st that NACI put out its recommendation that AstraZeneca shouldn't be given to people over 65. And I know this isn't your fault, but then on the second, new data comes out, and then on the third, new data comes out. Why did NACI wait so long after receiving what seems to be fairly concrete data that it's okay for 65-year-olds to get the vaccine? And how much damage do you think people will think of getting this vaccine? Because originally it was not for 65, now it is for 65. There's a lot of moving parts for this. Are you concerned that people would be hesitant to get this because of the moving parts?
Well, I think that everything that is moving tends to create or raise questions. In terms of the sequence of events, NACI was working on different questions at that point in time. And given the fact that these data were coming out and the fact that there were other alternatives in terms of vaccines available in Canada for the elderly population, we didn't necessarily modify the sequence of events. Maybe I can refer this to Matthew Tunis, the Executive Secretary of NACI, just because the process is more with the Secretariat, but the teams were busy with other files. Matthew, I don't know if you can add anything to this.
Yeah, sure. I mean, as Dr. Quach mentioned, the committee is very busy, obviously meeting weekly to discuss all the emerging data and these important topics. So there's always inevitably going to be a bit of a lag between when a committee deliberates and when the advice is made public. And as we've seen with this pandemic, as you mentioned, I mean, new data are coming out every day. And so it's an inherent feature of this kind of deliberative committee where we bring together these experts, convene them based on the available evidence, so they can make a decision at a point in time. Then that decision is made public, and as more evidence emerges, then the committee reconvenes, deliberates again, and updates their advice as they can. And I mean, there's really no other way to ensure a robust, stable discussion among a committee of so many experts. So I think we're going to continue to see this throughout the pandemic as new evidence emerges and is onboarded, that recommendations are going to have to change. And it might be that the evidence comes days after a decision, it might be weeks after a decision or months. We have no control over where data is coming from, and it's impossible to predict the future about what's going to come out on which day. So it's I think it's to some extent the nature of trying to do these careful deliberative decisions in this dynamic environment. Thank you.
And maybe I will just add that at that point in time, we were hoping to get the phase 3 or the randomized control trial from AstraZeneca that is currently done in the US, which includes more participants age 65 and over. We had the impression that these data would be available early to mid-March, and therefore we said, we see that there are studies coming out, but if we are going to change recommendation based on real world evidence, and if the phase 3 shows something different, what would move the needle most? And so at one point in time, you try and do some risk mitigation. At that point in time, we thought that AstraZeneca study would be ready, and then we learned later on in the week that it wouldn't be ready before April. And that's when we decided to look at the real world evidence and change our recommendation. But I think as Matthew said, it's easy looking backward to say, oh, you didn't have more data, so it was easy, you should have done it. But moving forward, there's always a cost of opportunity. So if you are to change something based on data from the real world that are in terms of hierarchy of data quality a little bit lower than randomized controlled trials data, and if your randomized controlled trial comes out the day after showing the opposite, then we would have been in a bind. So easy to say now that we should have, but moving forward, we did that in all good faith and tried to evaluate our options. Thank you.
Thank you. On va poursuivre avec Mélanie Marquis.
Merci, Martin. Je m'excuse pour le délai. La question est pour Dr. Quach. Comment réconcilier le fait que le comité aujourd'hui ouvre la porte plus grande à l'administration du vaccin AstraZeneca au fait qu'il y a toutes ces préoccupations en Europe? On a l'impression qu'eux appuient sur la pédale de frein alors que nous, on va plein gaz. Comment faire passer le message?
C'est une excellente question qu'on s'est posée hier. En fait, compte tenu que les médias savaient déjà tous qu'on avait changé notre recommandation, puisqu'on s'en était parlé. Hier soir, en fait, tout le monde disait que le CCNI avait modifié sa recommandation. On s'est donc dit qu'il fallait en parler et expliquer que Santé Canada, en fait, continue à faire le suivi de ce qui se passait en Europe. Je pense que notre recommandation n'est pas en lien avec ce qui se passe en Europe. Notre recommandation est vraiment en lien avec les données de Real World Effectiveness qui ont été publiées début mars. Et dans ce contexte, ce que je disais tout à l'heure, c'est que présentement, ce qu'on dit, c'est qu'il peut être utilisé, mais qu'évidemment, quand on évalue la balance des risques versus bénéfices, si jamais Santé Canada nous dit qu'effectivement, il y a un enjeu, on modifiera la recommandation, mais c'est le problème d'avoir un comité qui fonctionne avec des experts qui se rencontrent à toutes les semaines, où il y a un processus très strict à suivre, où les données doivent être revues, délibérées, rédigées, approuvées, traduites. Et donc, on n'est jamais capable de sortir une recommandation en deçà de 7 à 10 jours suivant la rencontre plénière. Et donc, je pense, encore une fois, là, il y avait une mitigation de risque où on s'est dit, soit on sort pas notre avis, mais il est déjà, en fait, dans les faits sorti puisque tout le monde en parlait. Et on attend, ou on fait cette recommandation-là, puis on permet la discussion là, autour des données qui existent présentement, où le lien de causalité n'est pas encore retenu.
En question de suivi, toujours pour vous, puis peut-être Dr. Berthiaume aussi, si vous voulez vous lancer dans la mêlée. Je sais que, bon, vous n'êtes pas le gouvernement, mais compte tenu qu'il y a une certaine hésitation, qu'il y a une population âgée de 65 ans et plus qui va hésiter à se faire administrer le vaccin, est-ce que ce serait pas sage de revoir un peu les listes de priorités pour s'organiser que, par exemple, le vaccin d'AstraZeneca soit donné en priorité à des populations plus jeunes?
Ça, je vous dirais que ça relève des provinces et des territoires. Nous, quand vous lisez notre recommandation, on demande, en fait, notre recommandation demeure préférentielle pour les vaccins ARN messagers dans les groupes à plus haut risque de complications. Nous avons quand même libéralisé l'utilisation du vaccin d'AstraZeneca pour les personnes plus âgées, mais après ça, les provinces pourront décider de l'utiliser comme elles voudront. Je pense que l'idée, c'était de permettre cette flexibilité-là aux provinces et aux territoires pour augmenter en fait l'offre de vaccination, pour être capable de vacciner le plus de personnes possible. Je pense qu'il faut quand même réaliser que dans les études dans la vraie vie, là, que le vaccin d'AstraZeneca avait quand même une efficacité de terrain entre 70 et 80 quelques % à prévenir les hospitalisations et les décès après une première dose, tel que rapporté par les deux grandes études faites en Grande-Bretagne. Je ne sais pas si Dr. Berthiaume veut rajouter quelque chose.
Oui, merci, Dr. Quashtan. Peut-être juste préciser que, dans le fond, l'ordre de priorisation des groupes pour la vaccination est déterminé sous les conseils du Comité consultatif national en immunisation. Ultimement, c'est déterminé par les autorités de santé publique. Le rôle de Santé Canada, c'est vraiment d'approuver les vaccins sur la base des données qui sont fournies, puis ensuite, la priorisation, dans le fond, de lequel vaccin est le plus indiqué, plus utile, le mieux pour tel groupe. Ces déterminations-là sont faites par la suite par d'autres groupes que Santé Canada.
Merci. We'll now go to David Thurton.
Hi. The audio is great during this press conference. We've had some issues with it in past Zoom ones, so thank you. I will say that someone's, I think, phone keeps going off. It sounds like a horn. You might want to just put that on mute.
And yeah, that's mine. I'm sorry. I'm on call.
Okay, totally. I did not know that. Apologies for that. And if there's any way that we could see the person who's speaking full screen, this is not anything that the people on the call can do. It's the people in the background. I know my TV colleagues would appreciate that. Right now, we're seeing like a 4-box version, but it's fine. The sound is great, so I appreciate that. So here's my question. If I heard you correctly, Dr. Quash, you're saying that where possible, the mRNA vaccine should be prioritized for people above the age of 65. I'm just wondering, in this period where people seem to be hesitant when it comes to vaccines, where people are saying they only want to choose certain vaccines, are you not afraid that this will worsen that situation or even encourage vaccine shopping?
Yeah, no, I understand what you're saying. I think that what NACI is aiming to do is to look at the evidence and try and give data that are, recommendations that are as much as possible hinging on those evidence. As I said, the mRNA vaccines had higher efficacy in clinical trials, in particular for those 65 years and over. I understand that in the AstraZeneca trial, there were less people 65 years and over, which could have made the vaccine estimate much less precise. However, these are the data we have. If the phase 3 trial that is currently ongoing in the US with AstraZeneca, with a larger number of people age 65 and over, shows us that vaccine efficacy is similar, then we will change our recommendation. But I'm not sure how to reconcile the 95% efficacy of the Pfizer-Moderna vaccine to the 75% of the AstraZeneca without putting some, differential recommendation there. And yes, I understand that, it would be easier to be able to say that all vaccines are equivalent. I think that from an efficacy perspective, they do not seem to be all equivalent, although it is very hard to compare all those vaccines head to head. However, we are currently, again, reviewing the real world effectiveness of the Pfizer compared to Moderna and AstraZeneca. And once all that is completed, if we see that in terms of vaccine effectiveness, the other vaccines are similar in terms of protection against hospitalization, complications, and death, it's possible that this recommendation changes. Ideally, we would do one recommendation with all the data in hand, but that's impossible. So that's why, you start with one thing and you start chewing that elephant slice by slice. I understand that it's not the ideal situation in terms of knowledge translation. It's then up to the communication people to chew that up. We make recommendations to the Public Health Agency of Canada, and then the Public Health Agency of Canada will communicate that recommendation out. So again, as I said before, we are an independent committee, and that is what the committee concluded, which doesn't mean that it's not going to change. But at this point in time, that is where we stand with the recommendation. I don't know if Matthew has anything to add. No? Okay, thanks.
No.
Thank you.
Yes, thank you for that, Dr. Quash. Just coming back to the big news out of this presser, you're changing your recommendation for AstraZeneca. You're now recommending it for people above the age of 65. I do have to ask, though, this is a change that we're seeing, you know, in a span of 2 weeks. Do you regret, Dr. Quash or Matthew, the unintended consequences of making this sudden change? And are you going to do anything differently? Have you learned anything from this?
You know, David, I think it's very complicated to know what's going to happen moving forward. When we did our recommendation end of February, it was issued March 1st, but we met end of February. We were in line with most countries in Europe. The data we had were the phase 3 trial data that AstraZeneca had submitted. And as I said, we had only one real world effectiveness from Scotland, which had methodological issues. And so at that point in time, the committee felt comfortable with what had been issued. In the week after, there were real world effectiveness data that came out, and then European countries started to change their recommendations, not all of them, but some of them. And as I said, the reason why we didn't jump right away on those real world effectiveness was because we were expecting the phase 3 trial data from the US to unveil in early March to mid-March. So we said, you know, if it's next week and those data are in contradiction with the real world effectiveness, we will not have done anybody a service. So I think that people have to realize that it's not that we're flip-flopping, it's just that we try to monitor the evidence. I think the only thing that I would say would have been done differently is the communication support, so that we would have been able to explain all this exactly as we're doing today. And so based on that, I think the Public Health Agency of Canada has now recognized that this support was absolutely necessary, and this is now put in place. Could have been done earlier, but you know, it's the first pandemic of this size, and it was the first time that we ran into so much complications. The unintended consequences, well, the provinces and territories were still able to use the vaccine as recommended by Health Canada. It was done in Quebec from the first week of March, like towards the end of that week. Others could have done the same. Again, it's always easier if Health Canada and NACI agree, but it doesn't have to be. It's not the first time it doesn't. It's not the first time NACI makes preferential recommendations. I think it's just the first time that people put so much spotlight on NACI's recommendation, and it's understandable. I mean, it's, you know, vaccines are what are going to get us out of this pandemic. But the way we function is the way we functioned before. In fact, we have had to increase the speed at which we are meeting and we are writing recommendations and we're approving them, which is an additional difficulty, I would say. But the only thing I would say is, had I known all of that would be coming down, so that the phase 3 trial from the US not be available before mid-April to end of April, and those two vaccine effectiveness coming out the days after the recommendation was made public, we would have waited before issuing it. But how can one know? I mean, I'm asking you, if you have a better crystal ball than I have, then by all means, please send it to me. I'll take it in a flash. Thank you.
We just have a few minutes left. We'll go to Mia Rabson.
Oh, sorry, am I unmuted now?
We hear you.
Sorry. I just had a bit of a follow-up about the recommendation to still prioritize mRNA for seniors. You said that the real-world evidence was showing similar effectiveness. I'm wondering if you could talk about that a little bit more and why that's not enough to say to not have that prioritization recommendation.
Yeah, thank you for that question. I'm not saying it's not enough. I'm just saying that it hasn't been formally reviewed by the committee yet. So we have the data, and it's going to be presented to the committee. And as I said, it's because it is a committee of experts, it's impossible for me or for the executive to change a recommendation right away. We have to look at the evidence, compare them, discuss them. And given everything else that has been going on in terms of moving parts, that is in the works, but is not yet finalized. So what I'm saying is it's possible that based on these real world evidence from the mRNA vaccines, that the preferential recommendation changes. But I can't presume of what the committee is going to say because it hasn't been debated yet.
Okay, perfect. Thank you so much. And I'm also wondering, in the overall guidance, it says that Pfizer in particular can be used on kids, I believe, as young as 12. But my understanding is that they haven't been fully tested on anyone under 16. So I'm wondering why we can make that recommendation for that population, and also what knowledge you have of when other kids might be allowed. Is it, or we've talked about the fact that everyone will get a vaccine by September, but it doesn't look like kids will be approved by then. So I'm just wondering if you can talk about kids a little bit and the vaccine.
Yes, absolutely. So the 12 to 15-year-old in the Pfizer data was based on data that were provided by the manufacturer upon their submission to Health Canada. They did not seek authorization because they didn't have enough data. But similarly to people with immunocompromising conditions, autoimmune diseases, pregnant women, we have left it in as a shared decision-making possibility, so that if a physician decides that that a given child is at very high risk and age, 15, there is something in there because we have some data. We will not make any recommendation on the vaccine use in children before we have data from the phase 3 trials that are currently enrolling children. From our understanding, we should get some data in the next 2 to 3 months for at least the 12 to 15-year-olds. And then as data are being accrued and are deemed to be, the vaccines are deemed to be safe and immunogenic, then they will decrease in age range until they go down to the younger ones. But we're not expecting anything for children before the end of 2021. Maybe Dr. Berthiaume from Health Canada has a better knowledge of what data are coming in and when, but we're not expecting anything anytime soon.
Thank you, Dr. Quashtan. No, not much to add. We should have data from Pfizer in the coming months. Data from Moderna maybe a bit later, but at this point in time, then the data will need to be reviewed, and it's going to depend on what can be derived in terms of efficacy from the data. So.
Thank you. Merci. C'est ce qui complète notre briefage technique. This is the end of our technical briefing. Reporters, if you have additional questions, you can reach us at hc.media.sc@canada.ca. Donc, les journalistes qui ont des questions supplémentaires peuvent nous joindre au hc.media, sans accent évidemment, .sc@canada.ca. Bonne journée.